I thought Dr. Todd Eldridge answered all the questions we could possibly have had about CIMT, but there were more. If you guys are new here, I am Dr. Lily Johnston. I'm a board-certified vascular surgeon, but I specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. At KE 64238 asks, CIMT may detect plaque, but now how do we get rid of it? Couple of things. This is a great question and one that comes up super frequently for me. The first question is, why do we think you have plaque? Because that will help us understand how we're going to go about stabilizing the plaque. Now, your question was get rid of it. And what I'll say about this is I just gave a whole lecture about plaque regression. This is a word we're hearing more and more as the science evolves. And when the scientists talk about plaque regression, they are talking about a quarter of a drop of water in terms of volume. So we're not really going to evaporate this whole plaque. It's not just going to go away. The only way to make it really go away is if you want me to get my scalpel out. And I can't recommend that for everybody unless it's really absolutely necessary. Short of that, we have a lot of strategies we can use to try and make the plaque stable. Because at the end of the day, plaque is not really the enemy. It is the best predictor we have of events like heart attack or stroke. But by itself, if it just stayed there forever, it would be okay, right? Most of the time, the plaque is not narrowing the vessel or narrowing the amount of blood getting through the vessel to the point where it's causing symptoms. Now, if you have chest pain whenever you walk, that's a different story. But for most people, once we find plaque on a CIMT, like early detection, just like we talked about, the answer is, how do we make sure that that plaque doesn't rupture? How do we create a stable dormant volcano instead of one that is about to erupt? And I think the key to this goes back to the first part of the question. Why do you have plaque? Is this a blood sugar and insulin resistance problem? Is this a toxic exposure like smoking or nicotine problem? Is this a family history, genetic predisposition problem? And none of these are immediately the only answer in isolation, right? But they do help focus our attention. So if we think that your ApoB is really well controlled, your blood sugar is really well controlled, but your homocysteine is 20, well, that's probably where we're going to focus our attention. It doesn't mean those other things don't matter, particularly if it's an ugly looking plaque or there's a lot more disease than we were expecting, or it's advanced for your age, anything like that. We will take a broad approach and sort of go after all the different levers we have. But we really would like to know what is driving this if we can. Not everybody has a super clear-cut answer, but that's certainly the approach I take in my clinic. And when I talk to others who are in the prevention space, it seems to be how everybody approaches this as well when I ask around. So thanks for that question. I'm sorry it's not a more straightforward answer, and I'm sorry the plaque won't just go away, but I do think that most of the time we can make it quiet and dormant and hopefully never become a problem. At Palandro Marco 5761, based on my modest experience with cardiac surgery in Italy, that's awesome. Thank you for being here on the channel. I can say that CIMT correlates very little with coronary artery disease. In Italy, an ultrasound of the supraaortic vessels, including CIMT, is routinely performed prior to every procedure. Setting aside studies and speaking strictly from the perspective of clinical practice, I have not found a strong correlation. So this is actually exactly what Todd was talking about, Dr. Eldridge, in our podcast, right? If you just get a single image and take the button on your ultrasound that says measure the IMT, and you're in the common carotid on one side, maybe even both, but it's just a single image, and you're not really looking at the presence of plaque, the IMT by itself is probably not that helpful. And it wouldn't surprise me to know that it doesn't correlate terribly well with coronary artery disease right before surgery. Some of that will be about, who is getting surgery, but moreover, I think the important thing here is for patients who also have plaque detected, and maybe that's what you mean, but I think, what I'm hearing, at least from the comment, is that we're just talking about IMT alone, that, a kind of protocol-less or a not terribly rigorous measurement of the IMT is not very helpful. And that's exactly what has been found in the US literature as well. The addition of this protocol and the ability to bring in plaque detection as part of the whole examination that CardioRisk performs, I think is where that technology really shines. Now, again, several of you said, well, I have millions of data points, just trust me. And we're a little bit miffed that Dr. Eldridge has not yet actually published all of his data. And there is I have that same instinct, right along with you. I deeply want for him to analyze and publish his data so that we can all have access to it. Because again, there is a little bit of this, like, just trust me, bro, and I get it. And I'm with you. I think it's the best we have, right? For a non-ionizing, meaning no radiation-based technique that is as rigorous as Dr. Eldridge has designed it. I think it's the best we have, and I do think there's good evidence that, again, with a standardized protocol in, a core lab-based scenario with the detection of plaque, there are reasons to believe this is an excellent screening technique and a great thing for us to incorporate in practice alongside other imaging technologies, right? You heard him say, it doesn't mean we throw out calcium screening or coronary angiography, right? The other imaging tools we have that look at the coronary circulation, particularly in high-risk patients. What it does mean is that if we have all of that information at baseline and we want to have a minimally invasive solution to monitor things going forward, maybe a CIMT is the way to go. If we're just doing screening and it's something I can do in my office at an initial visit with a patient, great. That is something we can offer without having to go through a CT scan. And again, it's not the whole solution, but I do think it's really an important piece of this puzzle. And I think it is important in my practice, but I appreciate you sharing your perspective. Thank you. At 4 lights, 5 lights, carotid Y-split inspection needs to be both left and right sides of the neck, more or less. Thanks for letting us know the fallacies of CIMT interpretations. So carotid Y-split, I think what you're talking about there is the carotid bifurcation, or where the common carotid artery splits into the internal carotid and the external carotid. And yes, that's called the carotid bulb. That is absolutely part of the CardioRisk protocol, and their protocol does absolutely also include both sides of the neck. So the IMT measurement that you get after a CardioRisk scan is about 300 measurements from the left side and about 300 measurements from the right side in the common carotid artery. But we also do evaluate for thickening and plaque in the carotid bulb and the internal carotid artery, which is the one that goes up to the brain. So those of us who operate on it would say that one's pretty important. Yes, I agree with you. All of these are a very important part of the protocol, and I wouldn't say that they're fallacies, but I would agree that CIMT as a bucket term is fraught. And when we are thinking about CardioRisk and a very specific protocol, I think that deserves to be elevated beyond the average person doing CIMT. But again, you get to judge that for yourself and let us know. Okay, another question from 4 lights, 5 lights. What about MRIs? So the question for MRI is really, what are you trying to figure out? MRI is non-radiation based, so it uses magnets to help us take really nice, pretty pictures. The issue with MRI is that it's not the best for blood flow or blood vessels. The blood moves pretty quickly relative to other tissues in the body. And so it can absolutely be imaged. There is something called MR angiography, or magnetic resonance MR angiography. It's pretty good. It's not as clean as a CT scan, and it does not have the same type of plaque detection or overlay technologies yet that we have for CT. So there's no formal plaque analysis, and what you usually get on an MRI actually looks more narrowed on the MRI scan than it typically looks in a CT or in true angiographic imaging. So MRI, in my opinion, in my practice, seems to be over sensitive, meaning it makes the artery look narrower than it really is. And I have a hard time seeing the other anatomy, and I have a hard time seeing plaque. Now, in a research setting, MRI can very successfully image different kinds of plaque, high-risk plaque, soft plaque. There are many different types of things that are seen in research. We don't really use them clinically. So if a patient comes to me with a desire to have an imaging test and they don't want any radiation, an MR angiogram can be an okay place to start, But if it's not normal, I'm almost certainly going to recommend a CT scan to give me a really much better picture of what I typically look at and how I typically look at it to get that additional information. And from a screening standpoint, yes, there's no radiation, but they're kind of tedious to get done. You have to lie very, very still in that very loud, small donut. And it's a little tricky. So if you have a reason to be getting an MRI anyway, it's not the worst test, but it's not one I rely on every day in my practice. And it's certainly not my first choice, even though it is doesn't have radiation. So generally speaking, I would prefer an ultrasound or a CT scan given my druthers, but for people who are trying to avoid radiation, it's okay. At Garrett7101, I just got my CIMT results, but don't know what to make of them. Didn't get any explanation. Garrett, that must be pretty frustrating. I'm sorry about that. If you got it from CardioRisk, I hope that you actually got the whole PDF report. I will say that is not super user-friendly. That is intended for your clinician, but again, many people are getting CIMTs now through CardioRisk without an ordering doctor, and like I love that that's super accessible. CardioRisk does now, I think, have an option where you can pay a little extra money and have the report interpreted for you with either somebody from their team or a partnering physician. I don't do that for them, but certainly when I am doing scans at events or for people who are not technically my patients, I certainly will try to interpret those results for them when I send people back their report. And then I always offer to hop on a quick call because it's not straightforward. What you have is the IMT measurement, which is the average. There's also a max IMT measurement. The average one is the one that determines your arterial age. And then there's the presence or absence of plaque and how much. Then in the comments, there will be an evaluation of the kind of plaque that's there, if any, and any comparison to a prior study that you may have had. This is hard to visualize without looking at it. If you want more information, I can recommend the video that I did going through my own report, where you can actually kind of see on the page where things are and how I interpret all of that. Obviously, your numbers will be different, but that should give you a sense for kind of how I walk through that. And also, this will be a nice plug for an Ask Me Anything coming up this weekend. We will be doing that Saturday live, 2 p.m. Pacific, 5 p.m. Eastern. I will not give individual medical advice, but if you put some numbers up there, I might mention how I would think about it in a patient of similar results or with a similar situation. So if you want to show up for the live Ask Me Anything, those are the kinds of things that we can go over. Okay, at Bill6450, is fundus photography or retinal imaging another good diagnostic tool for cardiovascular disease? Bill, thanks. This is super interesting because my gut answer is yes, it is, but I actually don't know as much about this as I wished I did. So we are going to do what we sometimes do here and go ask Open Evidence exactly where are we with taking pictures of the back of the eyeball to estimate cardiovascular risk. So the question, so the question about fundus photography, there are blood vessels in the back of the eyes, and it has been known for a long time that if we take pictures of these blood vessels, that they might tell us something, right? They tell us things about our eye health in general, but also maybe about blood vessels everywhere in the body. And a lot of this technology has been coming into the forefront recently. We have new techniques, new tech that is available for doctors to put in their offices and be taking pictures of everybody's eyeballs and screening, but I was not sure exactly where we were with how strong the data and evidence for this was, whether everybody should be doing this. And so here is the answer from Open Evidence. It says fundus photography and retinal imaging are promising evidence-based adjuncts for cardiovascular risk stratification, but they are not yet validated standalone tools for screening or diagnosing cardiovascular disease in routine practice. So to me, this means it's coming. We're getting there. A lot of the learning algorithms are coming on board to help us understand this better, but it's not quite ready for prime time yet. So it goes on, the retina offers a unique, non-invasive window into systemic microvasculature, so smaller blood vessels, right? The eyeball is a pretty small organ in general, and as you would imagine, the blood vessels that feed it are small. So these are structurally and physiologically analogous or similar to the coronary or the heart and the cerebral or the brain circulation. Specific microvascular signs correlate with both prevalent, meaning already existing, and incident, meaning going to happen, cardiovascular disease. But current expert consensus is that these biomarkers are supplementary risk enhancers rather than diagnostic replacements for established assessment, largely because of lack of standardized protocols, just like CIMT, device-to-device variability, and limited prospective external validation. So what does the evidence currently support? Retinal vessel caliber predicts events independently of traditional risk scores. So the ERIC study, atherosclerosis risk in communities, this is a very large, well-established cohort of about 10,000 patients. The narrower arterioles, meaning the arteries, and the wider venules independently predicted mortality and ischemic stroke in both sexes and coronary heart disease in women, which adds value to the pooled cohort equation or the risk calculator that we use when we plug your numbers in. So this is interesting because it means it's telling us something different that your blood pressure and your lipids and your family history don't. That's exciting. And there was a meta-analytic confirmation for coronary heart disease of 21 studies. Again, just looking at narrowing of the arteries, widening of the veins, and showing that this is associated with development of coronary disease, and stronger effects were seen in women and younger adults. And then we have AI-based learning biomarkers. So READY-CVD, which is a deep learning retinal biomarker, predicted incident, meaning future cardiovascular disease in the UK Biobank, and improved discrimination, again, when compared with the risk calculator that they use. We have said on this channel for a long time that the risk calculators are good at a population level. They are so-so at the individual level. And we are always looking for things we can use to better adjudicate risk in an individual patient. Imaging is a great technique. Again, I prefer ultrasound of the arteries in the neck because that's what I'm used to looking at. But I think if we're thinking about how do we broaden this to more and more people and get more and more screening done, this technique, especially if it can be done with kind of automated interpretation, and you don't need the physician who's in the practice to be interpreting every exam themselves. If the language models can do this, or the learning models can do this, then perhaps we are on our way to getting a radiation-free, wide-based screening modality, and that is very exciting. So key limitations before routine clinical adoption. There's a lot of variability, different devices, different models for scoring the images, and we don't yet have great external validation for most of these yet. So a National Heart, Lung, and Blood Institute, NHLBI roadmap emphasizes standardization of these biomarkers is really needed before we can recommend it in routine care. And predictive signal is often strongest in specific subgroups like women, younger adults, and borderline risk. So borderline risk, this is the same population for whom coronary calcification scores are recommended, CACs. And again, we are just using imaging to help better assess risk because, again, at a population level, these equations, not all that. So you can see some of the pictures here, what this looks like, and the different ways that we look at these images and how we are putting this all together, again, in conjunction with an individual's risk factors. So all that to say, I think it's a very promising technology. I think it's probably the way we are going to expand cardiovascular screening in the future, but I think we're probably a few years out from having this be something that we see in every individual practice. And until we have a little bit more standardization of the techniques, both the imaging technology itself, as well as the models that are going to score these images behind the scenes, we are probably not quite ready to be rolling this out for everybody yet. But stay tuned for more. I hope that was helpful. It was fun for me to learn about that with you guys. Until next time, take really good care.